because these will be either graduates or individuals highly involved with the D43 programs that Peter referred to. Our first, actually, in just the first three will be from our own Fogarty HIV research and training grants that we have in Eastern Europe and Central Asia. You'll hear a little bit more about these this afternoon on the Downstate piece, but just a couple of pieces of framework to keep you in mind as the speakers speak. First of all, these grants are really built on collaborative efforts within the SUNY system, and all of our D43 HIV research training grants are linkages between SUNY Downstate and the SUNY Albany School of Public Health. Another sort of interesting aspect of our work in Eastern Europe and Central Asia is medical schools there are sort of not based on the Flexnerian process of education, research, and clinical care, but it's really education and care. And so in each of our units, we work very closely with a research-oriented non-governmental organization or NGO, which is closely linked with an educational unit. And finally, in each of our countries, we collaborate with other US-based universities who are doing research or service activities in the region. For example, in Kazakhstan, we work with Columbia, in Ukraine with Yale, and in Georgia with Emory and NYU. So with that as a brief start, let me introduce Gokar Morganova, who you see, I think, right in front of you. She's chair of the Department of Epidemiology at Kazakh National Medical University, our primary training affiliate there, and also project director of the Global Health Research Center of Central Asia, or GERSHA, which is a research-oriented NGO developed in concert with Columbia University. Trained as a pediatrician, she joined GERSHA in 2019 and completed her MS in epidemiology at the University of Albany through our program soon thereafter, in 2014, actually. She's now involved in a COVID-related research grant funded by the COVID government, as well as a Fogarty grant. And we'll also speak today about her role as an MPI on an R21 done in collaboration with Columbia, looking at HIV stigma. So hopefully we can now turn it over to Gokar and give her presentation. This is going to be quite something if this works. Thank you.
Hello, everyone. Thank you very much for the possibility to talk today for this symposium. I will be talking about research opportunities and collaboration in Kazakhstan. And before I start doing that, I wanted to brief.
That's her and
that's pretty good for a moment.
Hello. So Kazakhstan is the largest country in Central Asia and has the longest border with Russia. The capital of the country is actually Nur Sultan. It was renamed 2 years ago, but before it was Astana. It's incorrect name on the map. I also decided to add some interesting facts about the country because, for example, for first artificial satellite Sputnik 1 and first man sent into space actually was sent from Baikonur Cosmodrome, which is located in Kazakhstan. I also serve as Dr. DeHovitz already mentioned, as the chief of epidemiology department in the Kazakh National Medical University. And because of the collaboration with the New York State International Training and Research Program, we have faculty members who are alumni of this program and who works in Department of Epidemiology and Biostatistics and implementing new updated disciplines in the university in Kazakhstan. Also, I wanted to talk a little bit about Global Health Research Center of Central Asia, the center that was founded by the Columbia University School of Social Work and Professor Nabila Elbasel and Aysel Terlikbayeva in Kazakhstan, in Almaty. We have a very strong team and conducted several studies, ARO1, R21, that are focused mostly on HIV prevention and treatment. Now I wanted to talk a little bit about epidemiology of HIV in Kazakhstan. As you can see, I included statistics for 2020 and 2021. You can see that the predominant way of HIV transmission in Kazakhstan now are heterosexual. You can see that almost 63% is heterosexual transmission. Also, in terms of cascade of HIV prevention and treatment, you can see the numbers. It's a long way to reach indicators 90, 95, 95, 95. HIV infection affects more male population than female. And also in terms of age distribution, HIV is concentrated in younger age group. I also wanted to talk more about research, crowdsourcing HIV, about crowdsourcing intervention, reducing HIV stigma and increase adolescent and young adults HIV testing. We decided to name this study JAS Spark, which means young spark. JAS is Kazakh word that means young. This study is a 2-year study, and I'm happy to be a principal investigator with amazing researcher Dr. Alisa Davis, and a strong team of co-investigators and consultants. This study will assess whether digital crowdsourced intervention can reduce HIV stigma and promote HIV self-testing among adolescents and young adults in Kazakhstan. So this study has 2 aims. These 2 aims actually corresponds to 2 phases of the study. In phase 1, we have to develop a crowdsourced digital HIV stigma reduction and self-testing intervention for youth in Kazakhstan. And aim 2 is included in phase 2, where we will use this crowdsourced HIV intervention and pilot test it to determine its efficacy. So here, as you can see, how the first phase of the study is organized. We announced a crowdsourcing intervention among adolescents and young adults to develop media content that is focused on reduction stigma against HIV testing. This contest will be conducted among, as I said, among adolescents and young adults. We expected that about 20 submissions. We will receive about 50 submissions, and we'll send for judging. And as a result of this process, we will receive top free media content that can be used for intervention. That will be used in the second phase of the study. So for the second phase of the study, we are going to recruit 168 adolescents from Almaty in the age from 16 to 24. They will go through baseline survey to evaluate baseline stigma against HIV and against HIV testing. Then they will be randomized into intervention arm, which will receive crowdsourced packaged intervention that already created by adolescents and young adults. And control arm will receive standard of care. Then we will, both groups will be recommended to use HIV self-test kits. And we will follow up both arms for 1 month and 3 months. And I wanted to talk a little bit about results of the first phase of the study, because we already started, we announced the crowdsourcing contest, and already received media content from our participants. And this is actually something we have never done before, and that was a very challenging but very interesting experience, because crowdsourcing approach is used mostly in business, and that was for the first time when we used it for public health problems, to solve some public health problems. So we involved a group of volunteers from adolescents and young adults to help us to create content for the content's promotion. So they helped us to manage accounts in Instagram, TikTok, Facebook, Telegram. We also invited popular bloggers, young bloggers who are popular among this population, and they also helped us to promote the contest, to attract more participants to participate in the contest. So some of our volunteers created video content, posts, and participated in many activities to attract more participants into the contest. This is interesting that all these instruments are possible to collect information and track how successful our approaches and how many potential participants we attract to participate in our contest. And you can see we could track, activities of our number of visits, number of viewers, what posts were more popular. We organized streams, and we could track how many streams people could watch, what streams were popular. And we had to adapt our strategy to the existing challenges and problems. So, for example, the concept of stigma and the stigma around HIV testing was a very complicated stigma. It was very hard to our young participants to understand what it is. And we provided links, references, and also organized Zoom webinars for students from several universities, and met with some school children in schools who were open to provide their audience for our communication. And one of the challenges that we didn't expect in our country is, some of you heard that in January we had a series of mass protests in Kazakhstan, and for 2 weeks we had no internet and then limited internet. Originally, we planned to finish contest by the end of February, but we had to extend deadline, and the deadline was moved to the end of March. As a result of all our work we did with organizing crowdsourcing contest, you can see that almost 4,000 people visited our site. Unique visitors was about 3,000, and finally of them 76 participants submitted media content to our contest. We also managed to keep track what were the best ways to communicate and disseminate information about the contest. And you can see that social media was the prevalent way how people get to know about our contest. So people used 60% used personal computers and 40% used smartphones. So, and here are some preliminary results. These are just quantitative results of contents and some characteristics of participants. And you can see that of 76 participants, from 76 participants, we received 91 submissions. We didn't limit participants in the number of media contents they could submit, so some participants submitted several contents. You also can see this is a geography of submission by regions of Kazakhstan, and we are happy to see that actually from all regions except one, we received any kind of participants. Of course, majority of participants were from Almaty, 37 participants, like almost half of participants were from Almaty. But Almaty, one of the biggest cities in Kazakhstan. And you can see that more than a third of our participants submitted video, pictures, and other types of contests. You also can see another third of our participants submitted other type of contents. Actually, we have one participant who went beyond our suggested formats and submitted quest and chatbot. And one participant developed a website with video, with text, with different types of contents. And for the contest, we divided our participants into two age groups to make the contest fair. So we had from 13 to 19, from 20 to 29. And you can see that the biggest part of our participants are from younger age group, which is very important for us. Some participants submitted group content, some individually, and 13, so it's about 15% of participants submitted content in Kazakh language. About that, we're also very happy because we wanted to receive content in Kazakh. So this is preliminary data that we received during our crowdsourcing contest. And now we are developing the process of evaluation of our content by panel of jury. They will be judging it. We will divide the panel of juries in groups in three, with representatives from young adults and adolescents, with representative of workers of aid centers and NGOs. And they will be evaluating this content using 4 criteria that were developed by the team of the researchers and discussed with consultants. And hopefully in 1 month, we will be having material for our intervention and can move to the second phase of this study.
Gokar, just 2 more minutes. Thank you.
Okay, so it's almost done. I just wanted to say that we are also planning, we are also conducting a study that is focused on impact of COVID-19 pandemic on people who live with HIV in Almaty. And another study which are conducted by the alumni of Fogarty program and the Department of Epidemiology of Kazakh National Medical University, and funded by the Ministry of Education in the Republic of Kazakhstan, and focused on COVID-19 influence on behavioral risk and lifestyle changes and vaccine hesitancy, COVID-19 vaccine hesitancy in Kazakhstan. So here is some ideas for future research. Thank you very much. I don't know if...
Great, thank you very much. And people are clapping here.
Thank you very much, I hope.
So we have about a minute or two for questions. If there's any from, I'll take any from the room now. I see none yet in the chat. Okay. Okay. Well, I think I'll ask one quickly to you, Gokar. You serve both in the research NGO as well as chair of the Department of Epidemiology. How is possible to balance those two efforts?
Yeah, it's very challenging to balance, but I think especially in epidemiology and public health, it is very important to be involved in the research in order to provide good training for students who will be working in public health sphere, because it's important that they can conduct their own research and understand data and provide good interpretation. And I'm very grateful to the actually it's because the open-mindedness of my supervisors in the university who are willing, who kind of open to this approach, and also in Global Health Research Center, they are also supporting me transferring research experience to students, because it's everybody understands it's important to transfer these skills to new generations. So it's joint efforts from not only from my side.
Great, thank you, and thank you for your presentation.
Thank you.
Okay. Next, we have a representative of our program from Ukraine. Don't need to tell this audience about the challenges that they've undergone, and I'm extraordinarily grateful to Kostya Domchev to appear today. Just briefly, he's scientific director of the Ukrainian Institute for Public Health Policy, again, a research NGO that we work with that is affiliated with our training site, the Kiev Mohyla Academy, our university. He's trained in narcology in Ukraine and received an MPH through Fogarty support at a program referred to as the ICORTA many years ago at the University of Alabama. He's had a series of succeedingly important roles in research in Kiev, having served with WHO, the CDC, and now serving as scientific director of the UIPHP. And he'll speak now about some of the challenges of working, as well as some of the work he's doing. Kostya, thanks so much for appearing. I really can't imagine what's going on there. Thank you.
Thank you, Jack. Thank you all. It's a really great opportunity for me to appear at this seminar, and I'm glad to be able to join it these days. So can you see my slides?
Yes, we can see your slides. We can see your slides, Koshu.
Okay. So just a few words about my first. So my Ukrainian Institute on Public Health Policy is a non-governmental research organization with almost now 2 decades of experience in various types of research. And historically, our main areas of interest were related to global public health threats like HIV, substance use, and mental health. And more recently, we're engaging in non-communicable diseases and hepatitis. Pretty big portfolio, maybe a largest portfolio of NIH-funded research in Ukraine. And, we also done studies funded by PEPFAR and the Global Fund and some other donors. We've done, different types of research, including surveys, clinical trials, a lot of implementation science, qualitative studies, and so on. We also have several projects which are non-research, not directly related to research, which are concentrated on capacity building for public health and medical workforce, and also in public health policy. Okay, so now coming to Ukrainian context, Ukraine has been on the news lately, so I won't go into too much detail, but just to emphasize a few points. Well, first of all, the war has begun much earlier in 2014, and this year we see just the open, fledged phase of it. And Russia really attacked us in 2014, and if the global response was as it is now, then probably this large war been prevented. But what we have now. So at this moment, these are very rough estimates, but there are about 5 million Ukrainians who have already left the country out of the total 40 million population, and about 8 million are internally displaced, meaning they're fleeing the areas that are affected by fighting, mostly in the east and south, the western parts. This is also relevant to public health, as you can imagine. There are lots of deaths. These are, again, these numbers change daily, and there are more than 2,000 civilian deaths already registered, and there are, God knows how many are still uncovered, and at least 100 children. Damage is uncountable. Ministry of Health reports there are more than 100 health facilities destroyed completely or partially. But again, this is not the end. And healthcare has been challenged in so many ways. As we are working mostly in chronic diseases like HIV, here are a few challenges that we see the most important. First of all, in those areas that are affected by active fighting, it's physically dangerous to go outside and visit health facilities. So therefore, people cannot visit their clinics for regular visits. And this, we are mostly working with HIV patients and patients with substance use disorder who receive opioid agonist treatment. These clinics also rely on continuous medication supply, and that the logistical chains have been broken since the very beginning. And many clinics face shortages of medications. Also, migration, as I've already mentioned, creates challenges and create uneven workload. For example, some clinics that in the east which continue to work, they have much fewer patients, and they are, and there is a question whether they should close or continue to work. Whereas others in the west, they see the big inflow of patients who migrated, who fled the eastern parts. Also, specifically for the opioid agonist treatment, some parts of Ukraine are already occupied, newly occupied, I would say, in the south, which is like Kherson region, Zaporizhia. And there are many clinics which provide methadone. And as you may know, Crimea, when Crimea was annexed in 2014, there were about 800 patients there. And since methadone is banned in Russia, this treatment was just completely stopped, and patients had to detoxify, but that is not very successful. And some patients have already died. These are documented things. So we are afraid that these sites in occupied areas may also stop working. They continue to work now, which I think is really shows courage of the staff there, who takes the risk to continue to provide these medications and also to ship the medications or to deliver medications to the sites, to Russian checkpoints. So about the public health response in these areas. So Ministry of Health and along with the Public Health Center have been working really hard since the very first day to try to mitigate these risks. And for chronic diseases, especially for methadone treatment, they've allowed take-home dispensing for 30 days. Previously, the limit was 10 days. Also, that simplifying the patient transfer procedures, simplifying medication redistribution, because really, once the central logistics were broken, I mean, the medication was delivered from like a few national level storages, but that was not possible for quite a long time. So medications had to be redistributed between the clinics and pharmacies, and that required really like daily manual to make possible. But this effort has largely been successful, and most clinics continue to work, except very hardly damaged cities, and also in the Donbass region, there are many sites in areas which are targeted by the new phase of offensive, and all civilian population is strongly advised to leave, and some sites in this area is also closed, unfortunately, and staff and patients hopefully have moved, but we know at least of one physician from Kramatorsk, from one of our clinics, who has been killed in the midst of strike at the train station. Also, the Ministry of Health, was working, but other neighboring countries were really grateful for them for offering an incredible amount of help and support. They've been accepting the patients, and Moldova was offered methadone to our patients like a couple of days after this started, and this is also really helped. About ourselves, so my institution, thankfully all our staff are safe, although only 2 people, including myself, are in Kyiv now, in capital where the main office is located. I've moved to another city, to my hometown, west from Kyiv, but now 2 weeks ago I returned to continue work. We did try to did our best to sustain our ongoing projects, to keep the work going. We were able to do so thanks to the COVID experience. We are now very used to remote work, and basically, productivity, of course, is not ideal, but we are able to maintain our key functions. No projects have been terminated, although we of course are facing delays. Some projects that are in data collection phase are they are able to continue it now, of course only in the areas that are safe. I will give you a few examples a little later. So we have several grants that are in preparatory phase, And we now, of course, making various adjustments to the context, not only from security standpoint, but also from emerging research priorities. And I also speak a little more about this. And we also think of new research opportunities. So now I will mention a few of our key projects.
More specifically,
sorry, I have to
evaluate the effect of a modified.
Sorry, you have to disable audio here. Okay, I think it's okay now. So yes, the first one is, sorry,
the first thing.
I had audio on this slide. I have to disable it somehow. So this one is an IDA-R1 study called Integrating Treatment for Mental Disorders in Methadone Clinics. And basically, this is an implementation science grant study that we are running. We have 12 sites all over Ukraine. We are providing them with antidepressants and kinds of treatment training for physicians to diagnose and treat depression. And we're also doing this like in a 3-arm trial or a cluster randomized trial design combined with different additional interventions like Project ECHO, which is a teleeducation intervention, and payment for performance, which is another evidence-based strategy to improve results. And we have a qualitative component to it, and then cost effectiveness component. So the design is described on this slide. So basically, all 12 sites are provided with MSBIRT, which is the base intervention, which includes antidepressants and for depression, is to train how to do that. And 2 arms are also participating in ECHO sessions, and 1 arm is receiving payment for performance. And we study various outcomes at the facility level and at the level. And we recruited a patient cohort of 100 patients, and it was followed up for 2 years. So current status is that we are now reaching the end of year 4. And we have finished the data collection. So the patient follow-up was finished in January this year. And for the next year, we were planning to do all data analysis, publications, also prepare for the new proposal, follow-up proposal, maybe some additional data collection. But this, with this. We want to change a little bit, and I will show you how. So, and those 12 sites that we worked at, we continue to provide services, and they continue to work, except one in Kramatorsk, which as I mentioned, is in the area which is targeted now the main focus of the offense. For year 5, we've just submitted our RPPR and proposed the following amendments to this project. Basically, we want to continue follow-up for the cohort to re-enroll the same cohort and to assess the changes in their mental health and substance use. Of course, in the, given this context, we expect a major impact on these variables. But I think it will be valuable to document how large it is. Also, we want to assess the scale and impact of patient migration, because we really, there is no sort of national registry yet for these patients, and we don't know how many had to move. We know there are many, but don't know how many. So in this, in this amendment, we may be able to document this for our 12 sites. And also to see how many in or out. because we have sites all over Ukraine. So we want to also expand the qualitative work with staff, or do a little survey with staff to see situation from their perspective. And also we will investigate the priorities for mental health interventions, because not only in patients, we expect that mental health could be affected in staff as well, and they may require some intervention. So this is the example of how we adjust to the new context. Another example of our studies is the supplement to the ongoing Fogarty Award, and Dr. DeHovitz is the PI of this award. And for year 5 and for the year 5, we've submitted an application for a supplement and were funded. And the idea was to study the impact of COVID pandemic on HIV services in Ukraine. And we've how it's the first component was to analyze quantitative data on the national level on various HIV services like HIV testing, care enrollment, ARV, and we finished it early this year. And and to the right you see two of most interesting graphs with the data, and there you can probably see that there is no evident correlation between, for example, number of HIV tests performed in facilities and the number of COVID cases, as well as that is the upper part. The lower part is the number of ART enrolled, and also there is a decrease, but it doesn't really correlate with COVID, with the number of COVID cases and deaths. So these are some interesting findings, and we want to analyze them. We plan to sort of investigate them in a qualitative phase, but when it was about to start, the war happened, and we of course were not able to continue it right away. But we do hope to do it. Some clinics and some experts have already responded, ready for qualitative interviews, and we hope other key people will also respond. And in condition of safety, we may conduct the interviews. And also the third component is development of training curricula responding to these challenges identified. Of course, this will probably will change because different, although they may be somewhat similar during the COVID emergency. Retention could have been one of the key gaps, and this is also very relevant in the current context. So we also plan to finish it with some delay. Another one is another big national level randomized clinical trial with we integrated opioid agonist treatment into primary care, and Dr. Altis from Yale University is the PI, whom you may know, with the integrated method on treatment in primary clinics, and studied the effect on the quality health indicators, as we call it, so basically integration of care. And, we are now in year 6, which is a no-cost extension, and over the course of the project, we created 12 clusters in 12 cities, which included a specialty clinic and 2 primary clinics. So there were 36 clinics in total. And actually, one of the clusters was located in Mariupol, the city which is now completely destroyed, as you may know. And but the cluster finished data collection late, in December past year. Now, but we continue to sort of follow up with our staff. Unfortunately, most of them have evacuated, and we're basically trying to help them with all we can, and even sending them some money because some of them had to leave without much stuff. Two other clusters were located in Kramatorsk and Slavyansk, which are the other two cities in Donbass, which are now affected, and sites are closed there. And we also helping staff to move out to evacuate. But other sites in this project in other areas continue to work and were able to continue data collection, which is planned for the remainder of this year in this study. And just one more example. This was a pilot project, but I know I really like it. This was also an implementation study, or in the pilot phase of simplified hepatitis C treatment, and we've done it last year with funding from one new European foundation. And as you can see to the right, we had pretty good results with treatment effectiveness. So we had like 95% sustained viral response at week 12. And this was implementation of hepatitis C treatment in another methadone clinics, because this is really a good opportunity to cover a large number of patients who need this treatment. And they now offer an opportunity for stage 2, which is a larger, with larger scale study of the same model. So we've applied for stage 2. The results are not announced yet, but we hope to be funded and to continue this research on large scale. But of course, in our application had to account for the changes in the context. But we are confident that the premise of this project or the relevance is very high now, because patients are still being treated. They still have hepatitis, and actually, another rationale is that the hepatitis medications which are procured by the Ministry of Health, they may expire soon and will be just wasted. But having the big number of patients on methadone provides a good opportunity to actually use the medications and treat people. Of course, we will have to adjust, for the issues like patient migration and retention, but in the intervention development, that all can be taken into account. So this is just another example of our basically future research intentions. And that would be it from my side. Sorry if I took it longer.
Wow. A lot of few claps here. Thank you so much, Kostya. Can't imagine how you can keep these projects up in that environment. It's hard enough doing it here. Any comments or questions from the audience today? Here. Sure, John, go ahead and press your button.
This is perhaps I want to thank you for your presentation and the amazing work that you're doing. First of all, that you're maintaining your programs under these circumstances is sort of beyond belief in some ways. So I congratulate you on that and on your perseverance. But I did have a kind of related question for Dr. Kilmarx. I'm just curious if there's what is the sort of thinking about how funding for programs in Ukraine might shift, whether that's for better or worse, or if there's any insights into the thinking at NIH for funding programs in Ukraine you could share, that'd be great.
Sure, thank you. I just want to add my congratulations and appreciation, really an impressive body of work that you're doing in Ukraine under any circumstances, and the fact that you're continuing, got some amazing results and lessons learned for all of us. So I would say in general, there's not, and unfortunately, these situations come up repeatedly with Myanmar, Afghanistan, and now Ukraine. We don't have a special pool of funds for such circumstances, but we are always as flexible, extend all flexibilities in terms of delays, extensions, and really try to accommodate these kinds of situations. And so it's really in terms of flexibilities of trying to facilitate if someone's was getting training in a situation in an institution that's now not feasible, they want to shift their training to another country or to the US to support that. If it's going to take additional time to complete a project, to have an extension on that, it's those kinds of reactions.
Great.
Yeah. If I may, from NIH, we've seen some, pretty good reactions from our project officers, and we hope that our ideas for next year, the grant I mentioned will be supported. And but most grateful we are that all our projects are able to work, and none of the funding has been stopped from the US side, so that is great. But we also some donors, they do announce special research opportunities which we hope to apply to, because we believe that additional research is needed not only to document the situation but to sustain service provision and recover at some point as well. So we are looking forward to additional opportunities to just a few words. Just I would really want to say a big thank you to all the international community, to the US, because we have lots of friends there and partners, and the support from the international community has been really incredible on all levels, on personal level, on the institutional level, on government level. And I do believe that all this support from all over the world, we will prevail, and Ukraine will will stay strong.
Thanks, Kostya. I think, Peter, do you want to make
I just wanted to add an anecdote. There was a situation in Zimbabwe in the mid 2000s, late 2000s, with the hyperinflation and economic collapse there. And there was a discussion, how could they possibly continue our programs, and we should stop their funding because there's no hope. And the counter argument was made, we actually really need to continue this. This is their lifeline to continue these activities. And that was the response, to continue. And really, they continued to be successful and still building on the successes from that era. So we really see this as a time not to withdraw support, but to try to extend additional support.
Great. I think we'll move on. Kostya, thank you so much for taking time.
Thank you.
We're so very grateful to you for your work in the past and even more now. Thank you. I have to take my breath now. Next, we will move to the country of Georgia. I'm pleased to introduce Dr. Mamuka Djibouti, who has been a colleague for many years, trained originally in neurology. He now leads another research NGO, Partnership for Research in Action for Health. We initially began working together about 10, 15 years ago when he served as founding dean of one of the schools of public health in Tbilisi, and then came together 2 or 3 years ago to put together a D43 HIV research training grant for Georgia, building on the very successful grant that we had jointly with University at Albany for many years through the HERP process. And I have to say that Georgia has been an incredible country to work with. I love all my countries, but the return rate in Georgia has been unbelievable. With that, Mamuka is now a PI of this D43, and I work with him as MPI. and he will speak briefly about the research environment in Georgia. Luca, thanks so much.
Thank you very much, Jack, and hello everyone. I'm really excited to be part of this meeting, and thanks again to organizers for giving me this opportunity. I guess I need to share my slides. Can you see my screen?
Yes, you might want to move to slideshow, but we can see your screen.
Yeah, let me do that. It should be better now.
Perfect, thank you.
Okay. So I will present today on behalf of Partnership for Research and Action for Health, which is the organization leading strategic training partnership for to end AIDS in the country of Georgia. So let me briefly formulate the outline of my presentation. So I'll try to briefly introduce the partnership, our organization, and then I'll talk about funding environment by focusing mostly on a current NIH funding and the projects we are implementing thanks to this funding. In the second part of my presentation, I'll be focusing on the priorities for the research, and for doing that, I will start with the general country context, and then focusing on public health research funding and infrastructure, like what is the environment for that in the country, and then followed by HIV and general health context, as well as healthcare system context. And these are all which are helping us, just to shape our priorities for our future work in the coming period. So let me start with our organization. As Jack mentioned, this is a not-for-profit, non-governmental organization, Partnership for Research for Health, which was founded back in 2006 in Georgia. And of course, it has the appropriate legal status and capacity to administer the funds for implementation of international donor-funded programs and grants. And our mandate is just to promote the health of the population, developing and implementing evidence-based policies and programs addressing most critical needs in population health. So this organization, like Partnership, was successful to establish Public Health Research Forum, and which is a strategic collaboration of national and international universities and scientific research centers and organizations. And this approach is very flexible and is very effective mechanism for international cooperation, and it allows us to mobilize resources, receiving grants, and implement projects. So now about the funding environment, and as I said, and Jack also mentioned that we are very successful to get this the funding for international research training, and actually, as Jack mentioned, this partnership started 15 years ago, and then we managed to get the 71 training grant first, And then we managed to continue with the current D43 grant. As I already said, we are recipients, the main recipients of this grant, and then we have two sub-awardees, and this is SUNY Downstate and SUNY Albany School of Public Health. And the period of performance is 2020-2024. And I'm one of the MPIs together with Dr. DeHovitz and Dr. Tony Hall. So, yeah, and well, I would really like to focus on the strengths of our partnership. I think that was the factor that helped us just to move with this funding opportunity and with this project. So as you can see on the screen, there are many partners engaged in this project, both from Georgia side and from the US side. So very briefly, you know, from the Georgian side, first of all, it's Tbilisi State University, which is host organization university for the doctoral program. We are supporting for this program. And then we have the other partners like National Center for Disease Control and Public Health and National TB Center, as well as other research organizations, non-governmental research organizations like Health Research Union, Kazakhstan International Foundation, and Institute of Social Studies and Analysis. As you can see on the US side, it's SUNY Downstate, the main partners, then SUNY Albany School of Public Health, then New York State Department of Health AIDS Institute, and last and not least, NYU School of Global Public Health. Very briefly about the program. So the main focus is the long-term training. As I said, we are supporting the doctoral program at Tbilisi State University, and by training 10 doctoral students. And let me also mention that part of this doctoral program, you know, will be done, you know, or is actually done at Albany School of Public Health, like 4 months duration for the coursework at the school, followed by 4 months practice-based internship at the AIDS Institute. So actually, our first cohort of Georgian students are already in Albany. They're just finishing the coursework at the school and will be starting soon their internship at the AIDS Institute. So scientific focus of this program is locally relevant HIV implementation research. And we are really trying to address the gaps behind first and second steps of HIV care cascades through doctoral research project. Just to give you an example, this is mostly focusing on insufficient HIV testing, HIV diagnosis, and linkage to care among key population groups, as well as integrated service delivery, HIV, HCV, TB screening, and similar integrated services. On top of that, we are focusing also on short-term training, again with a strong focus on implementation research, which is very new in Georgia, like in the region. And so we really try to train in implementation science, practicing public health researchers and postdoctoral students. And then the last component is building the institutional capacity just to support TSU doctoral program by improving quality of this doctoral program at that university. So recently, like my colleagues from Kazakhstan and the Ukraine, they already mentioned this HIV COVID-19 supplement project. So Georgia was also like our project was also the successful to get this funding, which is very relevant considering the current pandemic context, of course. And then, the key goal of this project is just to help to reduce stigma and other structural barriers to COVID-19 vaccination in the country of Georgia, and by improving healthcare worker knowledge on COVID-19 vaccination or HIV-affected population in our country. It has two major objectives or components. First one is just like needs assessment component, and we are doing this through quantitative and qualitative research to explore barriers at individual and healthcare worker levels by assessing the knowledge and attitude towards COVID-19 vaccination among people living with HIV, and also HIV-related stigma, discrimination, and other factors associated with vaccine hesitancy, which is a major issue in our country, like in the region. And then this will be followed by the development of training courses, which will be delivered among healthcare workers, again addressing stigma and other structural barriers to help to improve COVID-19 vaccination rates among people with living with HIV. So very briefly about the results, we just been able to conduct interim analysis of the data collected so far. So this is based on the data collected from 80 respondents among people living with HIV. You see median age 43 years, like around 50% males. And most interesting finding, as you can see, like around 50 to 53% of the respondent population, this target group, are vaccinated against COVID-19. And the other related findings, like only half of the respondents think that COVID-19 can be avoided by vaccination. And then the knowledge about COVID-19 and transmission of this infection and the transmission routes is very low actually. And the most of the respondents think that the COVID-19 is not any different among people living with HIV compared to general population, which again proves the importance of this project, and particularly the component which is addressing the improving knowledge and improving vaccination coverage in the targeted group. So now, as I said, this is the second part of our of my presentation, focusing on the priorities for future further research. And let me briefly talk about the general context for health research funding or public health research funding and infrastructure. So this is the map of the country of Georgia. You see, it's bordering with Russia, Turkey, Armenia, and Azerbaijan. Quite challenging, the situation considering what's happening now in Ukraine. And I don't really to focus a lot on this, as Kostya already presented the situation. And I just want to say that this is really affecting also situation in Georgia and has major implications for our country too. So about research funding and infrastructure. So Generally speaking, there is a limited funding for the research in the country. So just to show some figures, only the 0.2% of GDP, which is per capita 15 USD, is spent on research in the country, and this is based on the World Bank figures. And you can see how it compares with the similar figures, you know, of the EU, and we can see, you know, the huge difference there. On the positive side, we can say that there is an increasing trend in terms of availability of domestic funding for public health research, and this is made available through Rustaveli National Science Foundation, and which is definitely positive development what we are observing in the country. Well, we've been able to conduct recently one study which you know, was focusing on health research capacity needs in the country, and then we defined many research gaps in the country, in particularly national universities. But again, on the positive side, there is increasing pool of public health researchers trained in the US and the EU universities, which is very good, and the promising in terms of future of public health research in the country. And then the one particular, you know, the moment or characteristics for the country as for the region, I think Jack already mentioned that you know, for public health research studies, we use this collaborative you know, the approach, like implementing the different studies and programs through partnership between national universities, national public health centers, and research NGOs. So let me briefly focus on HIV and general health context in the country, because this is what is shaping the priorities for the future.
2-minute warning, Mamuka, if you can hear me. 2-minute warning. Thank you.
Okay. So then very briefly, so we have a very strong focus on HIV, but on the other hand, what you can see on this slide, you know, the considering the leading causes of death and the major risk factors, it's mostly non-communicable diseases, and also considering, you know, the increasing life expectancy of Georgia population. So the problem of chronic diseases or non-communicable diseases will become even bigger in the future. So we are really thinking to move to that kind of bridge, you know, the approach, moving from like starting from intersection of HIV and non-communicable diseases, and then eventually, you know, the leading us to address most prominent needs of population health in Georgia, which are non-communicable diseases, as I said. So in terms of healthcare system, yeah, there are it's improving trends in terms of universal health coverage, but, you know, still it's a challenge considering high share of out-of-pocket spending and also significant share of donor funding, particularly for HIV. So we really need to consider transitional period, which will come very soon, probably from donor funding to domestic funding. That's why we really want to keep very strong focus on implementation science to make sure that we help country to design and introduce innovative and cost-efficient interventions for HIV prevention services in particular. And this is last slide just showing, you know, some concrete examples of our efforts together with SUNY Downstate and other partners. Again, the priority is, as I said, intersection of HIV and non-communicable diseases, including neuropsychiatric disorders, and mental health issues among people HIV in Georgia. So I'll stop here and ready to take any questions. Thank you very much.
Wonderful. Thank you very much, Mamuka. Some claps here too. We have time for one question, if there's anything. And
I was just wondering what the situation with hepatitis C in Georgia is. I think it's been eliminated. If I'm not clear, if you could comment on that, please.
Yes, thank you very much for this question. Indeed, Georgia is, there's the country which is implementing the HCV elimination program through generous donor support from the United States again. And what we are seeing, it's a very promising results in terms of reduction of HCV prevalence. And then, the follow-up survey was done recently. So, I mean, in other words, these efforts are really showing good results. So this is major focus in the country.
thank you, Mamuka. So, and this now concludes the first part of the speakers from our D43 programs, and Jean Morse will introduce the next three. Thank you.
Great, thank you. Thanks to the presenters. Congratulations on how far those programs have been developed. I think I'll just mention, we didn't say earlier, but on the line, we have really quite a few other countries that are very interested in developing similar programs. I know there are groups on from Nigeria, Cape Town in South Africa, Uganda, and a variety of other countries. So as many of you are sitting here thinking about how did these programs get started, these are now 15, 20 years old, these programs that you're hearing about this morning. And we really think that's a key part of the SUNY Global Health Institute, is to help mentor other faculty across institutions to seek out these grants, build these types of programs, et cetera. So let's go on now. I think we're ready to introduce Professor Chiedza Mapanga, who is on the line from Harare in Zimbabwe, describing the program there. So welcome.
Professor Morse, I tried to just share not my screen is showing now.
Your screen, but not your presentation.
Okay. And now, sorry, let me know once I have gotten there.
We don't see it yet.
I think if you try to screen it from there, I think that.
We could show your slides for you and move them along and you can just tell us next slide if you.
Yes.
Okay.
Yes, please. Thank you.
Okay. Your slides are up.
The slides are on. Okay, so I am going to present slides that are showing our HIV clinical pharmacotherapeutics research training that reflects a collaboration between the State University of Buffalo and the University of Zimbabwe. I think you are looking at the first slide that shows our team members there. If we can move to this next slide. So this partnership has been on formally since 2008, even though the link between the State University of New York and the University of Zimbabwe had started about 10 years earlier. So our center is the Faculty of Medicine and the Health Sciences, which is the prime training center for research and education in health sciences. So our partnership developed strides. Yeah.
Yeah.
Oh, yes. Yeah, it's a little bit slow. Yeah. Okay. So I think we can wait there. The link is there. We are just showing where Zimbabwe is and where the University of Buffalo is. And our framework has been that we recognize that there are more resources on the US side of the Atlantic and resource limited on the Zimbabwean side. Next slide, please. So we set out to build a bridge, which is what we call technology transfer bridge, to share resources, particularly technology, but centered around skills building. Next slide, please. So the actual framework that we have become accustomed to is one where we identify space, like in this case, because we were focused on biomedical sciences, we know we are laboratory based, so we were housed at the Medicines Control Authority, which is the drug regulatory agencies in the country. And we build capacity around cutting edge technology through training. Then we train professionals and build research teams and approach the clinic, provide patient care. So in general, this has been the guiding framework for our collaboration. Next slide, please. Okay, so on the resource mobilization, you find that though our grant is focused on skills building, but those skills need equipment, so we often have to find other sources of donations, particularly from private sector. And in this case, we set out to build the lab from afresh. And what you see there is some of our scholars opening the first set of equipment that we got about 9 years ago. And what you see at the bottom there is what the lab looks like at the moment. Next slide. Okay, so the University of Zimbabwe, formerly called the College of Health Sciences, now Faculty of Medicine and Health Sciences, now has this international pharmacology specialty lab which has got cutting edge technology. And this is primarily what we use for providing pharmacology research support for scholars. Next slide. Okay, so in terms of administrative structure, so we have two arms. The blue side is really the UB, which is more blue, which is centered around the Center for Integrated Global Biomedical Sciences. And there you have, they have between the School of Pharmacy and the School of Medicine and an NIH Clinical Trials Unit, which is a sub-award from the Rochester University. And even more importantly, we have a clinical pharmacology quality assurance program, which really is what is needed for us when we are building our new lab here, so that we build it to standard. So what you have there on the right, which is light yellow, is the Faculty of Medicine side. So we have the HIV clinical pharmacology. And here in Zimbabwe, we also have the Clinical Trials Research Center funded by NIH, which is the CTU under the UZ Clinical Trials Research Center. The University of Zimbabwe has also built an innovation hub. And recently, we have acquired an affiliation center status for the Global Virus Network, through which the Abbott Pandemic Defense Network has come in, and we are participating in the virus surveillance program. So all this is really feeding into D43 clinical pharmacology therapeutics research, which in terms of administration, we have an executive committee which administers the D43. And we have mentors who are really key, and these are international mentors depending on what the need for each individual scholar. Then we also have the training advisory committee, and our area of focus is pre-doctoral and postdoctoral trainees at the moment. Next slide. Okay, this slide is slightly because it combines our former AIDS International Training Research Program, which we were funded for originally, and later on we were funded as the HIV Research and Training Program. But when we look at combined data, this slide is interesting in the sense that it has got some data which shows us, which tracks down where our scholars have gone to. And for example, 64% of our scholars have earned higher degrees from where we started with them. I also want to point out 63% of our trainees are women. And when we started, we were doing it deliberately, trying to make sure that there's gender mainstreaming, but lately, I think the law of averages has tended to favor female researchers for one very good reason. And I think this is really addressing a major disparity that has existed in almost most of the basic sciences here. And the other piece of data I would like to show there is that our scholars have really, the statistics, 77% of our scholars have been successful in getting extra research grants once they start working with us. Next slide. Okay, so now I am going to show you a series of publications that have come out of our work over the past 20 years. So the first set of publications is our programmatic publications. As you can see right at the top left there, we have to describe the 2 decades of collaboration of our HIV clinical pharmacology capacity building program. And this is very useful because we know that this will guide others in our region in doing the kind of thing that we're doing. And the top right corner, you can see the description of our mentor of postdoctoral research in Zimbabwe. And here we were reporting ourselves as a case study of what we have done so far. Just underneath it, you can see another publication on, we have a support group of patients, which started really as a community advisory group. And then we promoted some economic activities, that they were carrying out. And before you know it, really almost became partners to our research program. So our social workers who are really connecting us to the community led another publication on utility of HIV support groups in advanced implementation research in resource-limited settings, our experience there. In the left right corner, the lab that I was talking about, all the procedure. No, I'm still on that same slide. Just on the strategic establishment of International Pharmacology Specialty Lab, because we felt that maybe we need to share how we came up with the lab right from zero. Then we have got a pharmacogenomics HIV research that we are initiating, and the procedure that we followed and the framework that we used is also described in that other publication. And then in the right-hand corner, you see the development and validation of a high-performance liquid chromatography method. So at every step of our capacity building, we try to make sure that we do not lose an opportunity to collect data to share with others. So this set is our programmatic publications. Next slide. Okay, so our scholars, we have really been because we are talking about doctoral and postdoctoral. Here in Zimbabwe, for our doctoral, for our PhD, the requirement, one of the requirements that, for PhD, they publish at least 2 papers. And for postdoctoral training, we require at least 1 major paper. So our productivity has really reflected, been an example that can easily show the wide variety of areas that we cover. The top publication you see there is actually our HIV survival of HIV infected patients with high-grade lymphoma. And then on the right, you see our, viral therapy use with complementary medicines, another publication on pharmacokinetics of these drugs when they are co-administered. Then we have other therapeutic publications that you see, adverse drug reactions and pharmacokinetic studies there. Next slide. Another continuation of publications. On this one, what we are trying to show is, pharmaceutical sciences, quality of labeling of herbal medicines. We take that down because it really affects how, when those complementary medicines are taken with antiretroviral therapy, the efficacy through drug interactions and so on. So this study is about that and is showing results there. In the top right corner, you also see how we help set up a drug regulatory committee about medicine with the capacity for ethical and regulatory review of herbal trials in developing countries. In fact, this was a PhD student who did this study, and the local regulatory authority, once they got the results, they wrote a nice letter to the dean and said, thanking him, but also inviting this to be a member of the first committee for complementary at the Medicines Control Authority.
This is the 2-minute warning.
Sorry?
It's a 2-minute warning.
Okay, and I think that's the second last slide, where you have to see effectiveness of psychological intervention delivery in general nurses for alcohol use disorders. This is the health psychology. And the bottom 2 publications are nanotechnology. So basically, this is the range of areas of biomedical sciences that we cover. Next slide. Okay, so this is basically the summary. These are some of our postdoctoral scholars who have gone on to higher positions, including getting NIH grants in the areas that they started when they started working with us. The photos you have there are just appreciation photos for university leadership at the University of Zimbabwe. Next slide. Okay, so in summary, we start as a pharmacology capacity building program, but we find ourselves really transitioning into international global biomedical sciences research capacity building to address sustainable development goals. So the next slide is just showing our future priorities. Next slide. Okay, so that one again, the blue showing what is leveraging on the back side, and the green showing what we how we copy that and bring it into Zimbabwe. The feature that we need to show you there is that we now are thinking of we are now introducing a business development unit, because here in Zimbabwe, it is expected that research is being done must lead to either policy change or industrialization. So all the research that we have needed to be transitioned into policy and also develop new businesses. I think that was the last one. Next is just we are acknowledging the help that we have gotten from various organizations, including Fogarty, private companies, laboratories, Gilead Sciences, and for equipment, we have Waters Corporation. The photo that you see there is really showing a program that has been adopted by the US Embassy here, and our female scientists have gotten a grant funded by the US Embassy to support science, what they call STEM FEM, which is women in science. I thank you very much.
Thanks very much, Professor Mapanga. Good to see you. As you can see, each of the programs has a lot of enthusiasm. They each have full day conferences, so we're condensing them into 10 minutes, which is a challenge. All right, our next speaker will be Professor John Lindo from the University of the West Indies, Jamaica.
Off directly with. I know, I was going to set microphone. Where's my slides? Zoom home. Why am I seeing Charles on the screen? Yeah, that's he's more present on the eye. I think Professor Mapanga is still sharing.
Should I stop sharing?
Oh, no, you stop. We are not on the screen on this side though. Oh. Okay. We're good? All right. Thank you very much, everybody. Today I'm going to speak about the SUNY UA Health Research Consortium and how and just one program in that very large program that we have. The co-chairs are myself and Jean Morse from University at Buffalo. And I pointed this thing in the right direction. Yes. Okay. So just some background to our university. We started in February 1st, 1947 with 33 medical students at the Mona campus, which was an old refugee camp from the Second World War. So we started with 33 medical students because the health of the Caribbean people, as our vice chancellor liked to tell us, was the first in the British Empire. So we were a water upon the face of the empire at the time, and they decided they'd start a medical school to see to the improving the health. So that's where we started. I'm pressing the green one, right? No. Okay, this one. Okay, so where are we today? We are 4 block and mortar campuses at Mona, Jamaica, Cape Head in Barbados, St. Augustine in Trinidad, and the 5 Islands campus in Antigua. We also have what is called the Open Campus, which is an online campus. We have 17 contributing territories to our university system, and the Open Campus serves those non-block and mortar campuses and countries and territories. We also have global centers in China, and of course here with the SUNY UA Center for Leadership and Sustainable Development. I showed this slide because the Vice Chancellor liked it. You will see that we are going up in the rankings of global universities. However, we were marked down for industry income in the last survey of Times Higher Education World University Rankings. Our funding model, we are largely government funded. And you can see the green arrow, just look at the green arrow where the government funding is going down. So we have to find alternative models of funding. Our student numbers are going up. We are largely teaching university in terms of where the government funding is focused. So I tried to put some matrix in for Dr. Kilmarx, and I'll use a simple one. We are required to publish equal to or greater than 2 papers per year based on our contracts. What if we check the Web of Science, we're doing a little under 1. So we started in about 2012 when we launched a consortium. Well, we started as a health research task force. Then you'll see in the top left, Professor Morse, some members of the Jamaican diaspora in Buffalo, and we had the developmental phase and then the implementation period. Our second slide shows that we had the highest level of leadership. You will see Dr. Paul McCall from the trustees, the SUNY trustees, our Vice Chancellor Beckles, and the co-chairs of the SUNY UA Center for Development at the time. And then we had the consortium established in 2012. I point out in the last picture, Jeffrey Sachs in this very room, because of our link with sustainable development. And of course, you'll recognize in the bottom slide our principal at the Mona campus, Dale Weber, at the launch of the Global Virus Network with Bob Gallo. So at the start, we looked at what were our health research priorities. And we came up with the following: emerging infectious diseases, oncology, through diabetes and behavioral health. Now, this slide is not mine, but it's a very instructive slide because it shows you waves of epidemics of viral diseases passing through Jamaica and indeed through the rest of the Caribbean. So the focus of this talk will be on our global infectious diseases training program. You recognize Prof. Morse, Dr. Katie Anderson, who is sitting to my right, and John Lindo from the University of the West Indies, who are the leadership group for this initiative. As I said, it's one of a large number of initiatives that we have. So this was a Fogarty supported training program with the focus on major endemic or life-threatening emerging viral diseases. In a word, capacity building in virology at the University of West Indies. So our aim was to create a core of young investigators who would be the next wave of scientists with the training and the capacity to do independent research and of course compete internationally for grants. And this slide shows you the training program and our partners in SUNY in yellow, our extra partners from outside of the SUNY UE family, Rush, Chicago, where we had the immunology training core. And of course, I mentioned the Global Virus Network earlier on. We have centers now at the Mona campus, and the St. Augustine campus in Trinidad. And of course, we collaborate closely with the Ministry of Health so we can translate over policy and action. These are some of the students, a very hard slide to see. So let me just quickly point out a few. We have Dr. Lays, who is the second from the top, looking at HDLD1 infections. And we also have Tiffany Butterfield looking at immunometabolism. And on the other side, on the arbovirus side, I point out Simoy Noble, who is looking at arbovirus surveillance and pathogen discovery in mosquitoes. So, and finally, we have Dr. Samantha Mosher, who's looking at long-term impact of COVID. She's a pediatrician. She's a pediatric resident. I point these kids, scholars out because to show you the breadth of what we are trying to do. So it's not just about laboratory rats like myself doing laboratory things, but there's a wide variety of capacity building in virology. What are some of the outcomes? And as Jean said, I could be here talking all day, but I'm pointing this one out. We just had Tiffany Butterfield receiving her PhD with high commendation in March. Worthy of applause. And as I said before, she looked at immunometabolism in cardiovascular disease and diabetes in HIV infection. She's currently a postdoc in the program, and she started to publish quite well. These are 3 good papers in good journals, impact factor 5.5. So again, getting back to the matrix, and I hope if I'm invited next year, I'll have more complicated matrices. But you can see Tiffany is publishing and doing quite well. These are other publications on the program. One by Lays, looking at the response to the the AstraZeneca vaccine in Jamaican population. Another one including LACE, looking at seroprevalence of Zika and chickpea. Again, in very good journals, and so the Cameron, the fifth publication that I'm highlighting today. So the program, in my view, has been quite successful in capacity building, and we are very grateful for the work of the SUNY Global. Oh, my time is up. For the SUNY Global Institute and for the collaboration for us to have these good outcomes. Where are we going for the future? We are looking at building capacity in basic and clinical immunology. We have a UB Rush Becton Dickinson partnership where we're trying to establish a flow cytometry core. We have started work on the microbiome with UB Rush, and there's a grant application in progress. We're building out a prostate cancer center of excellence, and we are going to look at some diaspora studies of chronic diseases among Caribbean nationals at home and here in the US. And it's a very good place because there are a lot of Caribbean people living in this area. We also have started autism research. I should have said Andy that Andy Talal is one of our collaborators, and he's working with us on hepatitis C. My time is up, and so are my slides. Thank you very much for your attention.
Thanks, John. We're just going to keep going to keep us on schedule. We'll get back to some questions later if you have. And our next presenter is Irene Torres, who's joining us from the Fundación Actedro in Ecuador. And their program really is collaborative with the Upstate Medical University in Syracuse, New York. So welcome, Irene.
Thank you. Good morning, good afternoon. I am going to give a brief intro to the work of Upstate Medical University in Ecuador. The university has been for more than a decade in Ecuador and has different partners such as Walking Palms in the coast, Hospital Teófilo Dávila in the city of Machala, and the Technical University of Machala. It also has strong links with ESPOL, which is a university near the city of Machala in the coast of Ecuador, and with the Ecuadorian government, with, for example, the Public Health Institute of Ecuador, and with Fundación Otaedro more recently. The field site in Machala has 4 staff members currently. One of them is featured in a photo. And the site has worked with NSF in U.S. Department of Defense funding. There have been different and, as said here, impactful studies, such as the cohort and cluster studies for dengue virus, and also some respiratory surveillance efforts. It's actually, well, not an effort, a big study, which worked during the COVID pandemic. And this is important because the COVID pandemic in Ecuador was very, very dramatic. We had one of the highest excess death rates in the world during the pandemic. So it has been challenging and also quite exemplary that the studies continued during the pandemic, and it's still ongoing, like in the US, also in Ecuador. And it has a accredited clinical trial site, which is, as said here, unique for Ecuador, especially because it's in partnership with a public health hospital. And this is very important because public health institutions, meaning from the public sector, are not included much in research projects because of their dynamics and politics, but also because there's a lot of legal hurdles to achieve this. So it's quite an achievement for Ecuador and for Upstate as well. I'm going to talk very briefly about our experience with Upstate Medical University. Octado has been working since 1995 in the country. We do research projects. We also do research, social projects, and we have advocacy projects, and we also take part in government. We use it's called the empty chair in the City of Ecuador municipality. So we have a vote in local regulations, and we have expanded this project across Ecuador as well. So this is important because also Upstate is trying to bring a citizen science project to the country, and this would be very interesting. Regarding the funding environment, which was one of the questions for today's meeting, Ecuador invests very little of its gross development product in comparison, in research and development. In comparison, Brazil invests 1.2% of its GDP in research and development. And in Ecuador, most of it is actually private funding. This means that as I said, the public health sector, the public sector of health research is not developed. And as I explained, just with the Upstate Medical University and Public Hospital Partnership for a Clinical Trial Site, that accreditation, it's very cumbersome. The legal requirements are quite exacting. So the one successful collaboration we had with Upstate was the CKD research. It was the first epidemiological and health system analysis of chronic kidney disease in Ecuador. And this is important because it's a huge issue. It spends dialysis in Ecuador, only dialysis spends 11% of the total public health budget in Ecuador. The total money that is available for health in the public sector, not the Social Security, but the Ministry of Health health system, is spent in dialysis. So this was very important for the country. We have translated and we have disseminated. We still haven't garnered the attention that the study deserves, because the Ministry of Health says, yes, we know this, but the study does contain many pointers towards what the Ministry of Health could and should do. But then it becomes a problem of where is the money for this, right? So Upstate supported with the financial resources for the data collection, the expertise. There is not really chronic kidney disease research in Ecuador. And also the data analysis, which is also one of our, conducting research in Ecuador is difficult. We probably have one of the lowest rate of index publications in South America, one of the lowest, at least considering per capita number of publications. And Octado helped with the data collection. We have a very strong relationship with civil society, a good standing in Ecuador, and also we are an institution that has worked always in favor of Ecuadorian interest, and so there's a relationship of trust. Also the analysis, because we need a lot of local context. Okay, now I don't know how to return. Yes, local context to understand the data. That's very important, as you know. Just understanding the ICD codes in the databases that were shared with us, that needed local intel. So we published a +1 article. We're very proud of it. We're very happy. It was a lot of work to compile the data and analyze it in a way in which people could understand it, and it could be useful for decision makers, especially. That was the perspective of the study. So I'm very happy with those results, just understanding comorbidities, just mapping the gaps and the concentration of dialysis facilities in Ecuador shows you the disparities and the inequities in the health system. So this is very important. This is not something that the Ministry of Health commonly does. And another example of the collaboration, this was very spontaneous during the COVID pandemic. Octado partnered with different organizations like Los Alamos Laboratory, but also with Upstate. And this was very important. Till today, we have a very limited lab capacity. So just understanding this and disseminating and discussing, this was discussed with universities in the country and with public officials. And this is very important. This is knowledge that is important for the country and for decision making. So I like that this was possible with the support from Upstate. So for the future, and I'm keeping it short because we are running out of time, and I don't know if people have other plans to run out of the session or make more questions, but we want a second part. We have the data to focus on Mesoamerican nephropathy, which is a hypothetical climate sensitive chronic kidney disease. And also Octero has worked for some years on migration health. Now we're focusing at the borders. I don't know if you know about this, but there's 6 million Venezuelan refugees in the region, and 4.5 million of them are in South America, and 500,000 of them are in Ecuador, which is a very small country, only 17 million people, and we have 500,000 Venezuelan forced migrants. And so this is extremely important. And the humanitarian crisis synchronized with the pandemic crisis. And we continue to do the research, and we are still doing research. And we hope that with Upstate, we could integrate, for example, infectious disease diagnostic and information, which would be also very useful for the country, because the current projects of Upstate actually offer the government, the public health sector, the diagnostic of respiratory disease in children and also of dengue. There is very limited, as you saw in the lab capacity study, there's very limited dengue diagnostic capacity and respiratory virus diagnostic capacity in Ecuador. So it's also useful in that sense. And I think this is all I have to say. Yes, thank you very much.
Thanks very much, Irene. For the group that's here, we're going to try to take a photo before we break for lunch. We're also going to try to have a few questions right now. I did want to say there were a few confused looks during Irene's presentation. And I grew up down here on Long Island. So around here, when you say upstate, it means the Catskill Mountains. So I just wanted to, I know everybody looked a little confused, but actually upstate is in Syracuse. And the thruway goes to Albany, and then it goes all the way across. So I take this opportunity because I was a Long Islander at one point, so I can make that joke. Anyway, so what a great session. Let's just see, are there any questions, either on the chat or in the room?
Is the first speaker still here? Mapenga.
Use your button. Press the button in front of the mic.
That little white button. Next to the microphone.
Does it work?
Just to the right of the microphone. There's a little white button. Yeah.
There. Does it work now? Is Dr. Mapenga still here?
Dr. Mapanga is still there? Yes.
Yes, I'm here.
I was quite impressed
Yes.
with the transfer of your technology from Buffalo to Zimbabwe. Many medical centers in the United States have difficulty maintaining a robust clinical pharmacology program, both in US and in Canada. And it seems like you have a very successful one in your own institution. My question for you is, have you been able to expand that program to cardiovascular disease, antimicrobials, and psychoactive drugs commonly used in adults? And would you have improved outcomes and efficacy, et cetera?
I'll let Professor Mapanga answer that question.
Are you there?
Yes, thank you very much for recognizing that often it's difficult to maintain this. And I think that's why our framework, where we start by saying we need the buy-in of the highest authorities, and they show that by allocating space. they do that, we know through our collaborations that we can leverage other partners to come in and help us. So part of the success also is that we linked ourselves to other network research, and in particular, our pharmacology research was tied to the ACTG. So as a matter of fact, the PI, James Hakim, for ACTG here in Harare is the one who requested that we put up that lab. So all we had to do was to use this network, this networking to establish it. So going forward, we have been driven by what is the events that are taking place as a result of the development of the HIV, as we go. And now we are looking at comorbidities. So in terms of comorbidities, we haven't gone that far yet, except identifying behavioral health is joined in, and our scholars are from the Department of Psychiatry, and that's the work that we are looking at and to focus on going forward. So I think we have just been recently renewed. So in our next grant cycle, those are the areas that we are going to be focusing on. Thank you for your question.
And just to add one sentence to that, because the program was funded through Fogarty, through supplements, we've been able to request funding for HIV and cancer, HIV and dementia, and through that type of a funding mechanism, get the funding needed to develop those assays for those other non-HIV drugs.
Thank you.
Any other questions?
Can I ask another question? To our last speaker, Dr. Torres. I was quite impressed with their fundraising campaign for from private sources to support research. I wonder whether there's something that we can learn from them that we can apply to Brooklyn. Could you tell us a little bit more about how you raised those private funds, Dr. Torres?
Yes. Well, I'm talking about the country where the funding for research and R&D. You see, how we see it as a country is that shows that we're very unsuccessful in procuring funds, because the fact that they are private means that there's very little investment as compared to Brazil in terms of the percentage of the GDP, right? So we see it as a problem, not as a success, but I am happy that you see it as a success. Also very important, when we say R&D in Ecuador, we're not only limiting to scientific research. So it's understood as research and development. So for example, the government partners with private organizations to fund very small things that are considered development. Just to give you an example, the frozen food sector, learning how to improve packaging of frozen food will be considered an R&D project. So it's also maybe we're interpreting very generously what R&D is considered in the country. So I don't know if that answers your question of if I'm squashing your good spirit.
I'm not sure it would work in Brooklyn, but we'll try.
Thank you. Thank you, Irene.